Most adults over 60 who have experienced the pattern I am about to describe have explained it to themselves as constipation that got bad, and have managed it with the same approach they have always used for constipation: a stimulant laxative from the pharmacy, more water, waiting, and in many cases this works. But there is a specific progression of constipation that is different from ordinary constipation in a way that most people do not recognize until they are in a situation that requires emergency medical attention, and the difference is not simply one of severity, but of mechanism. What has happened in this progression is not that the bowel is slow. It is that stool has physically compacted into a mass in the rectum that cannot pass on its own, and that ordinary laxatives can actually worsen. This condition is fecal impaction, and it is specifically common in adults over 60 for reasons that are directly connected to the physiological changes of aging, the medications most common in this age group, and the dietary and activity patterns that accumulate over decades. Understanding what it is not, and specifically when a bowel problem has crossed the line from manageable constipation into a condition requiring medical evaluation, is the information I want to give you today. Before anything else, what I share here is educational information only. It is not medical advice. Fecal impaction is a medical condition that often requires clinical management, and the warning signs I am going to describe are reasons to seek medical evaluation, not to continue self-treating. If you are experiencing significant abdominal pain, bleeding, inability to pass stool or gas for more than 3 days, or the overflow diarrhea I will describe shortly, please seek medical evaluation promptly. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Subscribe to this channel now because every week I bring you specific, grounded information about what your body needs after 60. Let me explain what fecal impaction is physically, because understanding the mechanism immediately clarifies why it is different from ordinary constipation and why different management is required. When stool remains in the rectum and sigmoid colon longer than normal, the colon continues to absorb water from it. The longer the stool sits, the more water is extracted, and the harder and more compact the stool mass becomes. In ordinary constipation, this produces stool that is difficult to pass but that eventually moves through with adequate hydration, fiber, and time. In fecal impaction, the stool has become sufficiently hard and has formed a mass sufficiently large that it cannot deform to pass through the anal sphincter under normal straining effort. It is physically stuck. The body does not simply stop at this point. The bowel continues to produce fluid and mucus above the impacted mass, and softer, newer stool continues to accumulate above it. In some cases, liquid stool and mucus begin to seep around the hard impacted mass and leak out past the sphincter, producing what looks like diarrhea. This is called overflow diarrhea or spurious diarrhea, and it is one of the most dangerous diagnostic traps in this condition. The person experiencing it assumes that because liquid is passing, the bowel cannot be blocked, and continues managing it as though it were ordinary diarrhea, rather than recognizing it as a sign that the impaction is advanced enough to produce overflow. Adults over 60 are specifically vulnerable to fecal impaction for several reasons. The colonic transit time, the rate at which contents move through the large intestine, slows progressively with age, giving more opportunity for water extraction and stool hardening. The rectal sensation that signals the need to defecate, the awareness that the rectum is full and stool is ready to pass, diminishes with age, meaning that stool can accumulate in the rectum to a greater volume before the signal to evacuate is perceived. Pelvic floor muscle function declines, reducing the coordination of the evacuation reflex, and the most common medications in this age group, including opioid pain medications, calcium channel blockers, antidepressants with anticholinergic properties, and iron supplements, all slow colonic motility and contribute to the conditions that allow impaction to develop. The warning signs that distinguish fecal impaction from ordinary constipation are specific, and recognizing them early is the difference between an intervention that can be managed at home with appropriate guidance and one that requires emergency medical treatment. The most important is the combination of straining with little or nothing passing. In ordinary constipation, straining eventually produces some stool, perhaps with difficulty. In fecal impaction, repeated and significant straining produces nothing, or produces only small amounts of mucus or liquid, because the hard impacted mass is blocking the passage. Adults who have been straining repeatedly over 2 to 3 days without meaningful stool passage are describing a presentation that warrants medical evaluation rather than continued waiting or laxative escalation. Rectal fullness or pressure that is persistent and does not resolve is a specific symptom of rectal impaction. The sensation of constant rectal pressure, as though defecation is constantly imminent but not occurring, combined with an inability to achieve it, is characteristic of a mass that is occupying the rectal vault and activating the stretch receptors there without being able to pass. Abdominal bloating and distension that is progressive over days, combined with decreased or absent bowel sounds and nausea, indicates that the obstruction has become significant enough to affect the motility of the bowel above the impaction. This presentation warrants urgent medical evaluation because it suggests that the obstruction may be affecting more than just the rectum. Overflow diarrhea, the paradoxical liquid leakage I described, combined with the inability to achieve a formed bowel movement, despite persistent urge, is a specific pattern that should prompt urgent evaluation rather than anti-diarrheal treatment. Anti-diarrheal medications given to a person with overflow diarrhea secondary to fecal impaction can significantly worsen the impaction and the obstruction. Type in the comments now whether you or someone you know has experienced the overflow diarrhea pattern I described without realizing that it might indicate impaction rather than a gastrointestinal infection, because the frequency of that misunderstanding in those comments will tell me something important about how common this diagnostic confusion is. The urinary symptoms that can accompany fecal impaction are frequently not connected to the bowel by the person experiencing them, and they deserve specific mention because they can be alarming and because the connection between a packed rectum and bladder function is anatomically direct. The rectum sits directly posterior to the bladder in women and posterior to the prostate and bladder in men. A fecally impacted rectum exerts direct mechanical pressure on the posterior wall of the bladder, reducing its effective capacity and producing urinary urgency, frequency, and in some cases difficulty initiating urination or incomplete bladder emptying. Adults who develop sudden urinary symptoms alongside constipation, particularly urinary urgency or difficulty voiding, should specifically mention the constipation to their clinician because the two symptoms in combination point toward an impaction that is affecting both the bowel and the bladder simultaneously. And share this video right now with one person in your life over 60 who has chronic constipation and has been managing it independently, because the specific warning signs I am describing are ones that most people do not know to look for, and that, when present, indicate a situation that has moved beyond what self-management can safely address. And if you are not yet subscribed to this channel, tap that button now and ring the bell. Here is the framework for what to do and what not to do in different stages of this condition, because the appropriate intervention varies specifically with the severity of the presentation. For adults who are constipated but are still passing some stool, whose bowel movements are infrequent and difficult but occurring every 2 to 3 days, and who have no signs of the impaction I have described, standard first-line approaches remain appropriate. Increasing fluid intake to at least 2 liters per day, increasing dietary fiber from whole food sources rather than fiber supplements in the context of inadequate hydration, gentle physical activity that stimulates colonic motility through the ileocecal reflex, and osmotic laxatives such as polyethylene glycol, sold as Movicol or Miralax, which draw water into the bowel and soften stool without the cramping and urgency of stimulant laxatives. Osmotic laxatives are specifically preferable to stimulant laxatives such as Senna and bisacodyl in this context because they address the hardness of the stool rather than simply stimulating bowel contractions against a stool mass that is too hard to pass. For adults who have not passed stool for 3 or more days, who are straining without result, and who have the rectal fullness and pressure I described, medical evaluation is appropriate before continuing self-treatment. A clinician who performs a rectal examination can directly assess whether an impaction is present in the rectum and its degree, and can guide management accordingly. Attempting to self-treat a significant impaction with increasingly potent laxatives carries specific risks. Stimulant laxatives given to someone with a hard impacted mass can produce intense cramping and increased rectal pressure without clearing the impaction, and can in extreme cases contribute to bowel injury. For adults who have overflow diarrhea alongside inability to pass formed stool, who have significant abdominal pain and distension, who have urinary retention, or who are elderly and debilitated with signs of distress, urgent medical evaluation is required, and self-treatment should not be continued. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell. The medical management of established fecal impaction typically begins with manual disimpaction performed by a clinician, which involves the direct removal of the impacted stool from the rectum, followed by enema administration to clear the remaining stool above the impactee, and then the introduction of an ongoing bowel management program to prevent recurrence. The most important word in that sequence is prevention. Fecal impaction is a condition that, once it has occurred, is likely to recur unless the underlying risk factors are specifically addressed and a regular bowel maintenance program is established. The evidence-based bowel maintenance program for adults over 60 with established constipation or a history of impaction includes adequate fluid intake of at least 1.5 to 2 liters daily, which is the single most consistent contributor to stool consistency and transit, dietary fiber of 25 to 30 grams daily from whole food sources, including vegetables, fruits, legumes, and whole grains, with fiber supplements used only in addition to adequate fluid rather than as substitutes. Regular physical activity, particularly walking, which stimulates colonic transit through neural and hormonal pathways. A consistent toileting schedule, specifically attempting defecation at the same time each day, ideally 30 to 60 minutes after the first meal when the gastrocolic reflex is most active. And an osmotic laxative taken regularly rather than intermittently in adults with established chronic constipation, since the intermittent use of stimulant laxatives does not address the underlying motility problem and may contribute to laxative dependence over time. The medication review for adults with constipation should specifically examine which medications on the current list have constipating effects. Opioid analgesics, which should always be accompanied by a prescribed bowel regimen rather than an instruction to take laxatives if needed. Calcium channel blockers, which we discussed in our amlodipine video as having a direct effect on smooth muscle tone. Antidepressants with anticholinergic properties, antacid medications containing aluminum, and iron supplements. In some cases, alternatives with lower constipating potential are available, and in all cases, the bowel management program needs to account for and counteract the specific constipating mechanism of each medication present. 4 things to carry away. First, fecal impaction is physically different from ordinary constipation. It is a hard, compact stool mass in the rectum that cannot pass with normal straining effort, produces the sensation of constant rectal fullness without successful evacuation, and may produce overflow diarrhea as liquid seeps around the impacted mass. Overflow diarrhea in someone who cannot pass formed stool is impaction, until proven otherwise, not a gastrointestinal infection. Second, the warning signs that indicate medical evaluation rather than continued self-treatment are no stool passage in 3 or more days despite appropriate intervention, significant straining with nothing passing, progressive abdominal distension with nausea, overflow diarrhea, combined with inability to pass formed stool, urinary retention, or new urinary symptoms alongside constipation, and severe rectal or abdominal pain. Third, stimulant laxatives are not the appropriate treatment for established fecal impaction because they stimulate bowel contractions against a stool mass that is too hard to move. Osmotic laxatives that draw water into the bowel are the appropriate first-line pharmacological approach for constipation prevention, and manual disimpaction is the appropriate first step for established impaction. Fourth, the prevention of recurrence requires a specifically structured daily bowel regimen, 2 liters of fluid, adequate dietary fiber from whole food sources, regular physical activity, a consistent post-meal toileting schedule utilizing the gastrocolic reflex, and in adults with established chronic constipation, a regular osmotic laxative rather than intermittent stimulant use. Share this video with one adult over 60 in your life who has chronic constipation and has been managing it with intermittent stimulant laxatives without a structured prevention program, because the approach I have described specifically addresses the mechanisms that lead to impaction rather than simply managing the symptoms each time they occur. And subscribe to this channel, because every week I come here with one purpose: to give you the specific clinical information that prevents manageable conditions from becoming medical emergencies. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.